Good afternoon, everyone, and thank you for joining today's webinar on bidirectional communication with healthcare partners, key considerations for National Diabetes Prevention Program providers. I will now turn it over to Robin Soler, Senior Behavioral Scientist with CDC's Division of Diabetes Translation, to introduce today's speakers.
Thank you for joining us today. Thank you. We are in the second of a three-part webinar series. This series stems from work we've been doing with the YUSA, the American Medical Association, and CDC's Chronic Disease Center for Informatics and Information Resource Management, and an internal team of scientists, public health analysts, and contractors. This series is designed to provide you with an overview of how electronic health records, or EHRs, and supporting tools and systems are currently being used in the field for type 2 diabetes prevention. Our first webinar was an introduction for lifestyle change program providers using electronic health records for National Diabetes Prevention Program, referral, and feedback. The purpose of today's webinar is to explore learnings from a project funded by CDC looking at bidirectional communication between National Diabetes Prevention Program lifestyle change programs and healthcare providers. This webinar will explore what may influence successful implementation of bidirectional communication and provide a roadmap for organizations wishing to move forward down a path of effective bidirectional communication with healthcare partners to better meet the needs of the National Diabetes Prevention Lifestyle Change Program participants. Mapta Gakhar, Randall and Haley, and Susie Montessier are members of the Evidence-Based Health Intervention Division at the WISE National Resource Office, YMCA, of the YUSA. Mapta is the Director of Policy, Delivery, and Impact. Randallin is a Technical Advisor for Evidence-Based Health Interventions, and Susie is Manager of Program Delivery. Today, and along with other colleagues on the Healthcare Integration Team, Mapta, Randallin, and Susie support local YMCAs delivering YUSA evidence-based health interventions, such as the YMCA's Diabetes Prevention Program, along with other programs that help individuals prevent or delay the onset of chronic disease, as well as programs developed to help those living with chronic conditions live their healthiest lives. I'll now turn it over to Randall and Haley to begin today's presentation.
Hello, and again, thank you for joining us for the second part of our three-part series around bidirectional communication. As we move through this presentation, we plan to discuss a brief overview, making the case for bidirectional referrals and their benefits, a brief summary of the e-referral project, understanding the key drivers for bidirectional referrals, our implementation recommendations, and of course, we will have time for your questions and answers. We wanted to take a moment and level set with some key terms that you will hear throughout today's presentation. For purposes of this webinar, a referral is an order or prompt from a healthcare provider, or HCP, for a patient to participate in the National DPP Lifestyle Change Program. The National Diabetes Prevention Lifestyle Change Program, or National DPP-LCP, is any approved community-based, healthcare-based, or otherwise version of the National DPP-LCP. An electronic medical record, or EMR, is the digital version of the paper charts in the HCP's office. The electronic health record, or EHR, is often used interchangeably with EMR and has all of the same functions as an EMR, but includes a broader view of the patient's health and the ability to share information with other clinicians involved in the patient's care. And lastly, interoperability is the ability of different health information technology systems to seamlessly communicate and exchange data. A bidirectional referral considers both the information, the referral, going from the healthcare provider or system to the lifestyle change program, as well as information or feedback going back to the healthcare system or referring healthcare provider. As you can see from this graphic, the information, the communication should and can be fluid from both partners. Now let's take some time to discuss the benefits of bidirectional referrals and the current landscape around the use of referrals. Collaborative relationships formed between healthcare and lifestyle change programs can truly impact the health of the community, but this is unlikely without establishing effective lines of communication. Bidirectional referrals ensure information is moving between partners, increases the number of touch points a patient has, allows positive reinforcement from the healthcare provider, keeps the lifestyle change program front of mind with the healthcare provider, and improves continuity of care. All of these things are beneficial for healthcare providers and lifestyle change programs alike, but ultimately work to improve patient experience and impact health outcomes. The two most common referral methods include paper-based referrals and electronic referrals. A direct paper-based referral is typically sent via fax, mail, or email, allowing for proactive follow-up from the lifestyle change program, whereas an indirect paper referral happens when the physician hands the patient a referral with the onus on the patient to reach out. A direct electronic referral occurs by using the healthcare provider's EHR system to securely send the referral to the lifestyle change program, again, allowing for proactive follow-up by the lifestyle change program, whereas the indirect e-referral is sent to the EHR, from the EHR to the patient, placing the follow-up as the patient's responsibility. With the growing desire for an implementation of electronic health records within the healthcare system, the demand for electronic referrals or e-referrals has also increased. Optimally, the use of e-referrals helps streamline communication between the referring healthcare provider and the receiving clinic or partner. At its most functional use, it also helps provide HIPAA-compliant methods for communication and ensures that a referral is received in a timely manner. Oftentimes, the more traditional method of paper-based referrals being handed to a patient with the goal of the patient taking the next step to follow up adds to the potential for multiple drop-off points and leads to delay in care, or in some cases, no care at all. Bidirectional electronic pathways can remove the middleman and ensure the connection will be made and acted upon. As you may know, healthcare is shifting from the old fee-for-service model, where healthcare providers get paid for the amount of services they provide, to a value-based model, where value is defined as both improvement in quality and cost. Under the new model, providers are incentivized to use evidence-based medicine, engage patients, upgrade health IT, and use data analytics to get paid for their services. When patients receive more coordinated, appropriate, and effective care, providers are rewarded. As providers work to demonstrate value by improving their patients' health, they have to keep track of the referrals they make and the outcomes of those referrals, which requires bidirectional communication with partners that they refer to. This allows for quality, access, and efficiency to work together and overall improve outcomes. EHRs can help demonstrate value in healthcare by improving methods of referral tracking, allowing for increases in data-driven approaches, ensuring efficiency and functionality, and they also allow for timely and seamless care transitions by helping to avoid gaps in care. Simply put, the implementation of bidirectional referral pathways is instrumental in care coordination, and along with other system enhancements, such as clinical guidelines and registries, has the potential to reduce complications and even the incidence of chronic disease if used in conjunction with evidence-based health strategies that are proven to support behavior change and reduce risk. When a closed-loop communication is established and program providers share patient feedback with their referring healthcare partners, It enhances the ability of those partners to integrate this knowledge into clinical care and ultimately reinforce behavior change with their patients. In the end, working towards a reduction in complications and even the incidence of chronic disease. We'll now shift and discuss a brief overview of our project. With funding from the CDC's Division of Diabetes Translation, YMCA of the USA selected 4 local providers of the YMCA's Diabetes Prevention Program and worked with the American Medical Association and CDC to build and implement bidirectional e-referral communication pathways with existing healthcare partners using an EHR. As we began working through this project, it became clear through conversations with the local Ys and their healthcare partners the numerous challenges to implementing bidirectional e-referrals. And thus, we shifted our focus of the original project goals of increasing clinic-to-community linkages for bidirectional referrals and developing best practices to gaining a better understanding of the drivers and things to consider when thinking about implementing bidirectional e-referrals. And based on our wealth of learnings, we received both from the local Ys and their health partners. During this project, the Ys and their healthcare partners tested 2 main referral methods: remote call fax forwarding, where an analog fax line forwards an electronic or paper fax into an EHR, and direct messaging, a fully electronic communication from EHR to EHR. Additionally, they tested sending feedback to the healthcare providers by sending clinical letters electronically via the EHR. Here is a list of the project Ys and their healthcare partners. Please note that while it appears that many of the healthcare partners used Epic, it is important to remember that there are many different instances of Epic, and the versions used in this project were not the same. We would also like to take this time to thank our Ys and healthcare partners for all of their hard work on this project. Each Y experienced an increase over baseline from referring healthcare providers. Additionally, we recognize the project period is longer than the baseline, which could have also impacted the number of referrals. But one note of interest is that while referrals increased, we know it was not necessarily due to seamless integration of bidirectional e-referrals, as this didn't necessarily happen. But there were many important drivers at play, which we will discuss in this next section. I will now turn it over to Susie Montesier, Manager of Program Delivery, to discuss these drivers in greater detail.
Thanks, Randolyn. Hi, everyone. It's Susie. So I'm going to move us along into the key drivers section. So as we've been discussing throughout the project, it became really clear that there wasn't a single blueprint or a single best practice or way to really facilitate successful electronic bidirectional communication pathways. So what we decided to do instead was really try to categorize into these 4 main areas, so people, environment, process, and technology. What are the different considerations that might either facilitate or even limit implementation of bidirectional referrals and feedback? And often, or what we used to come up with these different drivers was a lot, based on the feedback from the local Ys that were a part of the project, as well as information that we gained from their healthcare providers as a part of key informant interviews and site visits. So a lot of this is what was gathered throughout the project. So one of the main areas that is really foundational is relationships. So it's absolutely critical that there is a strong relationship established and that it's positive between the lifestyle change program and the healthcare provider or the organization. And this can take time. It really isn't something that happens overnight. It takes a lot of convenings or meetings where both stakeholder groups are coming together and they're really understanding and demonstrating to one another what are all the inputs, what's going to be needed to make this work, and how can we continuously evaluate how we're going to work together, and how can we come together with a common goal and plan so that we are all on the same page and can execute all of this in the most feasible way possible. So again, this is something that really takes time. It doesn't happen overnight. The most important thing kind of happening at the outset is that trust that's being built between the different partners or stakeholders, and especially as we're thinking about ourselves or this audience as the lifestyle change program provider, really important that you're able to build that trust with those healthcare providers initially, so that they feel comfortable. They might not be used to referring to organizations that are community-based or organizations outside of their healthcare system. So really important that you're demonstrating the value that you bring to the table, and it is a tremendous value, so don't ever undersell yourselves. But really important that they have a good understanding of that, and then they'll feel more comfortable referring their patients. Another thing that we've noted with this area of relationships is that it's really important to try and use a team-based approach, so that it's not just one person from your organization working with one person from that practice or that hospital or whatever that setting might be, because we've found that if there is staff turnover, then it's almost like you're starting from scratch with that relationship, and you don't want all that hard work to go to waste. So really important that there's a team-based approach, and that, that there is this more, I guess, robust relationship that's being established across multiple stakeholders, so that if there is a change or, someone goes on leave or something happens like that, all the work that you put into this is not lost. So again, in an ideal state, both stakeholder groups have a shared understanding of each group's inputs and expectations. There's a clear sense of shared desired outcomes, and if possible, a formal partnership, some sort of memorandum of understanding or a more formal agreement being in place that clearly outlines these things is always helpful. It's always helpful to have something to refer back to, something in writing. We know that it's not always easy to get to that place, but that can be really helpful if along that continuum the relationship evolves to that place. So along the same lines of relationships is this area of healthcare provider champions. This came up, I would say, across all the sites that were a part of this project, and as a theme I would say we continue to hear, especially with our work with LocalWise, working with healthcare partners. And the importance of champions is that this is someone that's really passionate about this. This is someone that's driven, someone that really is invested in this work and really does value the Lifestyle Change Program and your organization. So by having that champion in place, they can then help spread the word. They can motivate others within their practice or system. They can encourage buy-in and contribution. Sometimes, healthcare providers only want to hear from their peers, their other healthcare providers, So there might be folks that aren't as open or aren't as familiar with working with a community-based organization, and so it's really important that we can identify as early as possible who is someone that can really champion these efforts and really kind of drive, what might need to happen even incrementally. So whether it's providing input on workflows, helping to integrate clinical guidelines into the patient identification and decision support processes. They might be able to answer questions from their peers as things start to get implemented. They might be able to provide feedback on the process that you're working on together. So really important to think about who this could be. And in an ideal state, it doesn't really have to necessarily be a physician or the chief medical officer or someone with a specific title. We've seen champions kind of run the gamut. So it's really, what's important is that they're engaged and they want to, commit some time and effort to this, and they do have a voice within their organization. They do have the ability to leverage. So this could be a physician, a nurse or a nurse practitioner, a physician assistant, registered dietitian. even office managers, so kind of the front of the house staff that really know everyone and know everything about how their organization functions. Those folks can also be really influential as well. And as we mentioned, important, although it might just be one person initially, think about a team-based model so that, again, if that provider champion moves on, something changes, all the work that you've put into this relationship and the partnership doesn't go away. So think about how the healthcare provider champion network can even be expanded. And now I'm going to shift over to the bucket of environment. So just a few drivers in this section, and one that's, I think, really complex is the reimbursement climate. So folks might be aware that the prediabetes as a condition or a diagnosis is really still a newer term. It's still a newer concept for healthcare providers. And oftentimes, even if healthcare providers are familiar with prediabetes and are aware of the importance of screening and diagnosing, they might not be aware of you all. They might not be aware of the National Diabetes Prevention Program, Lifestyle Change Program, and the ability to even refer their patients into such a program. So because of that and because of the absence of consistent mechanisms for appropriate coverage or payment, it can be really difficult or it can be a variable that healthcare providers are having to either focus on or be distracted by. So for example, if a healthcare provider does become aware of the Lifestyle Change Program that is in their community that they can refer their patients to, if they don't know if there's coverage for that program or coverage doesn't exist, or they don't know that there might be other opportunities to help subsidize those costs, they might just not refer at all. They might be, just not comfortable with that lack of understanding of the cost of the program or the reimbursement situation. So that, I think, can pose a lot of challenge. But on the flip side, there are some things that are really positive in this space. Things like, Medicare coverage going into effect. This could absolutely increase awareness and can bring coverage to a large percentage of the population, though we know the number of Medicare suppliers is still quite small, but still it can help raise awareness of this important program and the fact that, more coverage is at least coming into play. Another thing that we already talked about, Randolyn, was covering this whole shift from fee-for-service to pay-for-performance and basically moving from volume-based to value-based care. So as healthcare systems focus on this, healthcare providers are increasingly becoming aware of the importance of demonstrating improved quality and efficiency and ultimately lowering costs and needing to demonstrate that in payer contracts. So as healthcare providers are kind of feeling that pressure, or their system or organization is feeling that pressure, they might be more likely to really think about how they can bring down those costs by referring their patients to a lifestyle change program and ultimately improving the health of their patients. So in an ideal state, healthcare providers are aware of options. They're aware of benefits of the program. And then if there is coverage, I know it varies across the country and each individual region is different, but if they're aware of what coverage exists and if coverage doesn't exist, what are the resources that are out there to help subsidize costs, that is something that can really help facilitate bidirectional communication. So as a lifestyle change program provider, it's important to kind of know what are all these different variables within the reimbursement space. So another environmental consideration, I think everyone probably is aware of this, that there are a lot of competing priorities within the healthcare system. So I think just like, the organizations that we all work for, healthcare providers also have a number of hats to wear, a number of competing priorities that on a daily basis can feel like a lot to really manage. So especially as we've been talking about moving from volume-based to value-based, that just in itself might limit the ability of healthcare providers to really focus in on something as specific as diabetes prevention when they have hundreds of other things to worry about when their patient comes in. Primarily they're focused on what is the patient here to see me for today, what are their maybe chief complaints, and then, okay, maybe can we go through this checklist of what other things might they be at risk for, what other things do I need to screen them for. It's really a lot to cover in a very small amount of time that they have with that patient. So in addition to that, healthcare providers are often in different stages for even developing processes and infrastructure to improve their patient care. So, they might actually be going through a process with their organization where they're focused on one specific clinical quality measure. So, for example, they might be focused on reducing avoidable hospital readmissions, because this is often something that's incentivized for healthcare providers. If they are a part of an accountable care organization, for example, they might be focused specifically on that one metric. So if they're focused on that, how are they going to have the ability to incorporate something like prediabetes into their workflow? That just might be one potential challenge. Because there are no clinical quality measures related to the national DPP, LCP at this time, it just might get pushed lower on the list in terms of competing priorities. So really important to think about as a strategic way to kind of, make sure this doesn't get lost is how can a process or workflow that you would work with your healthcare partner be something that could be duplicated for other efforts, other conditions, other screenings, other, components of the workflow within the practice, so that it's not only specific to diabetes prevention, but it could be, replicated to individuals with diabetes or hypertension screening or any of the other things that healthcare providers are going to have to focus on at some point. So that takes me to our section around process. So one area that I'm guessing folks on the call are familiar with is prediabetes awareness, or rather lack of prediabetes awareness. So this is something that continues to be a challenge. I think we've seen the awareness has increased slightly over time, but it's still quite low in terms of individuals, knowing that they are at risk for type 2 diabetes. And I think folks have probably heard the statistic that, of the 84 million adults in the United States with prediabetes, only 10% are aware of their condition. So really important that, our healthcare provider partners are kind of activated around that and understand that it's essential for them to kind of reinforce what, are the factors that might put someone at risk, and reinforce that, if someone does have prediabetes, they might not fully know the benefits that they could receive by participating in a diabetes prevention program. So really important that the healthcare provider kind of acts on that and reinforces that this is something that's available, and type 2 diabetes can be prevented or delayed, and so really helping to kind of tap into that and tap into what might motivate an individual to participate in such a program. So in an ideal state, healthcare providers are, they have this front of mind, and anytime they interact with someone that might be at risk, they're either screening or, and or referring their patients to a national DPP lifestyle change program, so that they can work on behavior change and lifestyle change to hopefully reduce their risk or delay the onset of type 2 diabetes. So shifting gears a little bit, still in the process area, but we have been, one of the focus areas was initially this whole concept of bidirectional electronic communication. So the electronic processes themselves have quite a few different variables within them as it relates to key drivers. So we wanted to spend a little bit of time talking about this in itself. So, it is feasible to have a fully electronic referral process within a given organization or within an electronic healthcare record. But the challenges that we tend to see are when two different organizations or two different systems are trying to communicate with one another electronically. So it's one thing for two physicians within the same healthcare system or the same practice to kind of implement workflows so that they can communicate seamlessly with one another. But where the challenge arises is when we, introduce the healthcare provider needing to communicate outside of their group or outside of their system. So even if they're communicating with a partner that uses the exact same electronic medical record system, there are many challenges that arise. There are different instances of those systems. There are firewalls. There are HIPAA considerations. There's just a lot that kind of goes into this bucket of interoperability challenges. So when we're thinking about this, it's really important to just consider that this space is really complex. And when we're talking about electronic processes, we're talking about both outbound referrals, so the information that goes from the healthcare provider to the lifestyle change program, as well as inbound feedback. So what is the information that healthcare provider is going to want to receive? So, progress information, for example, once someone enrolls in the lifestyle change program. We do, we have heard and we do tend to see that a lot of healthcare providers are more increasingly becoming responsible for closing a referral loop. So if they do make a referral electronically, they're needing to somehow document within their system what happened to that referral. So that, makes it instrumental for the lifestyle change program to be able to communicate back what happened with that referral. Otherwise, that person is essentially lost to follow-up. And so if a healthcare provider can know that, I referred my patient, but they didn't follow through or they didn't enroll, then there's an opportunity for them to continue following up with that patient and hopefully allowing that person to eventually enroll in the program. So as I mentioned, that those inbound updates are really important. So that is something that needs to be factored in here. And, one thing that can be a significant variable is also just the different regulations, HIPAA regulations, IT compatibility, risk management requirements. So oftentimes what we see when we're talking about electronic bidirectional communication, there's this whole side that needs to be factored in that might require individuals from within, within both organizations to really work together on what all the different processes might be and what are the considerations. So in an ideal state, IT, HIPAA, and risk management requirements are addressed and as early as possible in the development and testing because that could potentially put up a roadblock if it becomes apparent later on that those things weren't considered. Also in an ideal state, outbound referrals contain sufficient information. So both for the lifestyle change program, they need to be able to receive all the information that they would need to know about a potential participant in the program so that they can ultimately enroll that person in the program and contact that person. And then as well as the information, the inbound feedback information needs to be, really should be determined with the partner at the beginning so that they are receiving information that's helpful for them. We've heard of examples where, just information was sent back that wasn't used by them or wasn't helpful to the partner. And so really important, and again, to kind of reinforce and support and build the case for continued referrals from your healthcare partners is that you're providing them the information that they want and that they can use. And every healthcare provider might be different. One provider might want information only about whether or not someone enrolled. Another provider might want outcomes. They might want to know when someone completed and what their average weight loss was at the end of the program. So really important that you're working with your partners and figuring out the data content, the data format, and the timing and the frequency of that communication. And ideally, the healthcare provider is able to integrate any inbound feedback that they would receive from you into their patient's chart so that they can continuously follow up and reinforce all of the hard work that their patient might be doing as a part of the program. Another area that's important around process that we heard repeatedly is the importance of training and continuing education. I think we hear a lot from program providers that, we went and visited, our partner, our healthcare partner, and we told them about the program, and they were fully on board, and they started to refer, and then 6 months later there was a huge drop-off. We stopped receiving referrals. We don't know what happened. Well, as we were talking about, there are a lot of competing priorities for healthcare providers and LCPs alike. So really important that this is kept front of mind, and there are opportunities for continuing education and training, both about the availability, so making sure it's known that you are a provider and this is your capacity where you provide the program, and that you're out there and ready and willing to accept referrals. Also, regular training to healthcare organization staff on what the program is, who qualifies for the program, what to expect after someone is referred. Those are things that can be easily forgotten or kind of pushed off to the side if it's not revisited. Also important for, staff at your own organization, just, what are the best practices for how to manage a referral, how to communicate, and closing that feedback loop. And so in an ideal state, this is something that isn't just a one and done. It's something that's revisited as much as it can be. And we've even seen examples where LCPs were able to obtain continuing medical education or CME credits for healthcare providers to learn about the lifestyle change program, so that there was something kind of a carrot there for providers to continuously gain access to this information, and that did seem to lend itself to an increase in the number of referrals. So of course we couldn't have this section unless we talked about the importance of evaluation. This sometimes gets forgotten. It's sometimes an afterthought, but evaluation is really important, and thinking about it right from the beginning, not waiting, okay, 2 years into this relationship, what should we evaluate and how? So if organizations are, if the goal is to increase the number of referrals into the program, organizations working together should really think early on, how are we going to assess our success? How are we going to measure if what we're doing is working? How are we going to make sure that if we have challenges along the way that we're not just going with the flow, and we're going to stop and we're going to address and make change and figure out areas to target for improvement. So there are different ways that this could be done, different reports or feedback from staff that are directly connected to the process. But ideally, evaluation plans are developed right from the beginning. And there's, an ability for continuous improvement from all stakeholders. And it's, we know it's not going to be simple, and so it's important to kind of address this whole, it's not going to be perfect from the start. There's going to be trial and error. There's going to be goals that we set, and we might not always achieve those goals. And ultimately, how can we minimize frustration and work together for long-term sustainability? So, one way that organizations might do this is, implementing continuous PDSA cycles or quality improvement rapid cycles, so that, it is something that's always front of mind, and it is always something that both teams, both sides of the partnership are always thinking about and assessing. So again, electronic electronic health record systems themselves. So I was, speaking to this a little bit earlier on, just both the positives around electronic health record systems, all the potential opportunities that they offer and capabilities to capture data and communicate across systems and within systems, but also just the challenges that exist in the marketplace. There are multiple systems which, can allow for universal processes for bidirectional communication, but how they're actually operationalized can really be challenging. So this whole issue around or factor around technology is an important one to consider. And within each organization, both for the healthcare provider as well as the lifestyle change program, the knowledge and comfort of using these systems is going to vary from individual to individual. So, in some cases, I think we've seen where, a healthcare provider champion, for example, was really savvy with how their EHR system worked and all the different options that they could either activate or streamline or put into a workflow to help facilitate bidirectional communication. In other examples, there might be someone very engaged and supportive of this work and wants to make referrals and does make referrals, but they have no idea how to manipulate their EHR system. And so in that case, others within that organization might need to be engaged, and it might take time to figure out, how do we use this system that we have to really optimize bidirectional communication. And what we also learned throughout this project that I think was significant was just that, many organizations, it seems, are having to use additional kind of add-on platforms or external management systems, so something that's not their kind of foundational or, their I'm drawing a blank on the word, the out-of-the-box EHR system doesn't necessarily accomplish everything they need it to. So organizations increasingly are having to look at other kind of add-on technologies or platforms to help facilitate things like patient identification, patient referrals, and just referral management itself, since it seems like the EHR system has a lot of jobs or tasks that it must do. And sometimes the whole, referral management piece is kind of an afterthought. And then additionally, we know that many, if not most, lifestyle change programs are not using an EHR, and that's okay. I mean, that is something, that the Y began kind of using, and it, it's not easy, and it's not expected that everyone would be using an EHR. So what does that kind of pose when, working with a healthcare provider that is using an EHR system? So in an ideal state, there will be advancements for interoperability to allow for more automated or fully electronic transfer of information between care team members, and that would include the lifestyle change programs. So, again, I think we kind of see that healthcare organizations might be able to really move the needle for communication within their own organization, but the challenge really seems to come when healthcare providers are trying to communicate with other healthcare provider systems, so maybe a specialist or someone, in a different state or a different system, or lifestyle change programs or other community-based organizations that are not within their own network. So we know there's a lot of work kind of being done at the national level or, throughout the country to really help move the needle here. But it's going to take some time. This concept of interoperability is a large and complex one. We have seen, some functionality that seems to work maybe a little bit more seamless, and that would be something like direct messaging, which Randolyn had mentioned was one of the things that the local Ys that were a part of this project tested out. And so that was a more seamless electronic method for information to go or for information to come from the healthcare provider. And so, kind of minimizing the burden of having to fax or use paper, that is, something that ideally would function and be feasible. And then, as I mentioned, there are these add-on modules or different external systems or platforms that could help facilitate, and I think we're exploring and seeing more examples of this. So we listed on here just a couple that we've seen used. So Pareto is one. It's a kind of a referral management software that healthcare providers can gain access to or link to their EHR system. Aunt Bertha, maybe folks on the line have heard of that one, and it's another, you could Google it, but it's another kind of platform or cloud-based system that basically allows individuals to kind of look up what options might exist within their community for referral. And then REDCap is another it's a data system, again, cloud-based, but a way to track and manage data. And all of these options, just might be more accessible than an EHR system, lower cost, and maybe even more user-friendly to help facilitate that data transfer between EHRs or from EHRs to, another program management system or solution that's used by the LCP. So I know that was a lot. I know the drivers are kind of a heavy section, and there's a lot of detail in there, but hopefully helpful to kind of just provide more context of what we learned over the course of the project. And now I'm going to transition it over to Mamta Gacker, who's going to talk about some recommendations for LCPs.
Thank you, Susie. So I think we share these drivers in part just to help folks understand some of what we learned as, through our experiences with the project that we did in collaboration with CDC and AMA, and also just to help for folks on the line who are thinking about this work, think about what might be some of the areas that they will want to proactively address or plan for. This next section is really, again, very broadly thinking through if you are a provider of the diabetes prevention program, you're a lifestyle change program provider, and you're thinking about tackling this work, if you're already continuing this work and want to move it forward, we wanted to share some very high-level recommendations, again, based on our learnings about ways where to start and where to go next once you've started. Not necessarily, again, suggesting that this is the single approach to doing this, but more just to give some ideas about how you might begin. And we could spend hours and weeks and months talking about this. I think all of you who are on the line and have connected to this world probably would agree. So these are very broad and high level, but we're happy to also dig in offline with folks to share a little bit more about our learnings. And I just wanted to quickly say, since we've gotten a couple questions in the chat about this, the webinar is being recorded, and that in addition to the slides will be made available once all of the recordings are converted and hosted. And so folks who your colleagues who weren't able to be on this call will have access to that, and if you want to access the information again, you'll have access as well. So we'll make sure that information gets sent out once that recording is finalized. So as I talk through the recommendations for LCPs, just showing this graphic, this is kind of the buckets that we've grouped our implementation recommendations into. And you'll see it's sort of cyclical and circular, not necessarily that you have to start in one place, because, of course, you could already be doing this work. And we wanted to acknowledge that people are in different places when we talk about the spectrum of this work. So just know that that's kind of, it's grouped this way. It doesn't necessarily mean that you start in one place and only move linearly forward. You might be revisiting, and as Susie said, it might be that you're doing some rapid cycle improvements to kind of figure out how to continually improve your processes or your relationships or your ability to receive referrals and share feedback. But we are going to talk about it in the context of internal capacity assessment, relationship building and cultivation, understanding of landscape and opportunity, project planning and scope, and implementation and evaluation over the next few slides. So in terms of assessing internal capacity, we talk about that. We really wanted to, we were really talking about helping organizations think through how they figure out where they are and where they want to be. So taking some time to identify your current approach for engaging with the healthcare community for referrals for the program, if you are doing this currently, and if so, how far along are you? If not, where would you like to be in 1 or 2 or 5 years? Or even if you are, where would you like to go? And starting to have a plan, thinking through based on where you are and where you want to be, what that might mean for for your next steps. We suggest thinking through the drivers that we listed on previous slides to determine whether they apply to your current context, and if so, how they might apply. Again, this was really based on our learnings for this particular project. We do think in some cases they are probably universal, and as we've connected to other LCPs or other organizations that have been approaching this work, we are hearing similar themes. But again, every situation is unique, every community is unique, so we offer those as suggestions for places to tackle your work or your energy, but of course there could be other things that are at play in your communities. In terms of additional assessment around your internal capacity, thinking through your financial resources, your current relationships with the healthcare community, who are you currently talking to, who might you already be receiving referrals from, if you have those current relationships. Current staffing, this does take a lot of energy, so what kind of staffing can you allocate toward building those relationships, as Susie mentioned, and working through processes for referral. Thinking through your technology, your functions and limitations, whether you have leadership support and training needs. It's really just, echoing all those drivers and figuring out how all those drivers really apply to you. On these slides, we've included a couple examples of assessment tools, just if you maybe haven't done this type of work before, you haven't done that kind of organizational assessment. One of these tools for these links could give you a place to start, helping guide some questions that you might ask internally or other ways that you might evaluate your current capacity for thinking through bidirectional communication with healthcare providers. So once you've done that assessment, likely you're going to find multiple areas that where you might want to move the needle. And I think chances are that it's probably going to be more feasible to just pick a few areas to focus on initially, but that over time that you might be addressing different areas of your organizational analysis. So setting project goals, creating a target timeline, developing a staffing plan, again, really thinking through how to be intentional about this work, because it is something that does, at least as we've observed it, require a lot of thoughtfulness and a lot of attention and time and resources in some cases. And I think thinking through, as part of your capacity assessment, is thinking through the value that you provide as an LCP, that we want to make sure that we're being very clear about the value that we can provide to the healthcare partners and systems in our community, and really crafting that into a pitch, for lack of a better word, because it's really important that that in order for those partnerships to be cultivated and grown, that we really are meeting each other's needs. So thinking through that in advance and being thoughtful about how you might have those conversations and incorporate your pitch into those conversations. And data always helps, so looking at where you can access local data on your program, community data, as well as national statistics that can be worked into your pitch. In terms of relationship building and cultivation, Susie talked a little bit earlier in the driver section about the importance of relationships. I mean, that it's really key and crucial that you're thinking through how you might address this piece. So you'll want to identify who you're going to work with, and a lot of you on the call already have relationships with the healthcare community. So thinking through where you have existing relationships that can be leveraged, where you might want to form new relationships. You might want to think about some kind of market analysis. So who are the big, maybe healthcare systems in your community? We might have the larger penetration, or if there are community hospitals or FQHCs, if it makes sense to target your energy there, that you have a sense of that healthcare community landscape to help identify where you might want to focus your energy. It's not necessarily, it might not be that you might have multiple healthcare partnerships, but you don't necessarily want to start with each. So really thinking through where it makes sense, who is your intended audience, and based on that, a large healthcare system might be, a large hospital system might have different needs than an FQHC. That can help you refine your approach for how you might engage those individuals or find the individuals within those systems to speak with and then share your plan and hopefully grow a relationship. Once you identify who those people are or those organizations are, learning about their needs, so being really open and asking questions about what their pain points are, what they might be trying to address within their context, what their goals are, so you can understand better. As we go back to that pitch idea, understand better how your organization can define its value within the context of their goals. Again, we're trying to meet needs, and we have a lot to offer the healthcare community, so thinking through how we can make that clear to them. And then defining your opportunities, so using conversations to inform your strategy and build relationships. And we really think, based on our learning, that it's key to craft these relationships and partnerships in a way that's mutually beneficial, that it's not so much that we're saying yes to everything. We have to make sure we can do things that are feasible for us and that are meeting our needs as well, but thinking through how we create a partnership that is a true partnership where everyone is sharing accountability and we're all working toward aligned and shared goals and visions. So understanding the landscape and opportunity, in addition to understanding the healthcare landscape, so knowing what's happening within the healthcare system, within your communities is important, but really also trying to figure out, Susie talked earlier about EHR, she talked about electronic processes, and understanding what, if you are trying to develop bidirectional communication, especially one that is going to be electronic, what options are available to you? What could you potentially implement? So thinking through, reviewing literature, trends in the field to understand a little bit more about how bidirectional referrals have previously been implemented successfully to help prepare for potential challenges and limitations, or even to help you think through what might be an approach that would make sense for you to tackle. Maybe talking to other LCPs in your community about how they've partnered with healthcare organizations for referrals. If there's something, if you have strong collaboration efforts in your community and there's stuff that could be built upon and duplicated or replicated rather than completely reinventing the wheel, that might be a good place, or it might be a good way to target your approach. Talking to maybe other organizations like state health departments, and we've listed NACDD here, the National Association of Chronic Disease Directors, who they might be focusing efforts on ways to address some of these interoperability challenges that we've been talking about, finding bridges to connect non-clinical program providers with their healthcare partners to address population health. And NACDD has been doing a lot of work around this with a project and a tool called eConnect. So there might be existing avenues to think through or to maybe connect to that can help figure out how to make some of this a little bit more seamless. If it's not specifically EHR to EHR, it might be EHR to some bridge system, then back to another EHR. Or not necessarily even originating from an EHR if you are an LCP that has not adopted the use of an electronic health record. And then also talk to your healthcare partners to see, are they already working with other providers of services that are maybe not clinical in nature, not necessarily other LCPs, although it could be inclusive of that, but do they have other practice extenders, or are there other community-based referrals that they might be providing, and how have they been handling the referrals and the feedback loops with that? Again, Susie talked a lot about the competing priorities within a healthcare system, and I think where we can leverage existing workflows and just apply them to this service, we're all better off for it. I think it helps a lot with continuity and sustainability. So, if you have existing healthcare partners, or as you're approaching these conversations, what might they already be doing, and is it something that could just be replicated? If you are working in an EHR, you have some kind of data system, doing some homework to understand the functionalities within, what might be different approaches. And, as we were doing this project, we spent a lot of time working within our electronic health record within AthenaNet to kind of figure out which functions are available within the system that we could test and hopefully refine for the purposes of communication with the healthcare partners. And there might be some different functionalities that are available in the systems that you're using that could help with this. So thinking through what might be some solutions or might be some channels for communication, and you'll need to be familiar with your own data system in order to do that. But you'll want to make sure that you can answer questions when you're having those discussions with the healthcare partners on about what options there are to share information on patients. If your healthcare partners are working in EHRs, if you can do your best to develop a working knowledge of those systems, it doesn't mean that you have to adopt the use of those systems, or it doesn't mean that you have to become experts certainly in those systems. And again, a lot of those systems are very complex, and there may be different instances. So even within that, it's not necessarily going to be a one-size-fits-all approach, but just being familiar even with the language that is common in electronic health records. Susie talked about the use of add-on modules or other that aren't necessarily EHR platforms. Be familiar with those as options that can help with, not only data management, but potentially referral management. So Pareto, Ambertha, REDCap, those are the ones she talked about. There's also Referral MD, Fibroblast, and these are typically, or at least these examples specifically, are HIPAA-compliant web-based applications in some sense that are really have been used for referral management and to address patient leakage. The idea of that, like a referral is made and then there's never any follow-up or action on that. So those might be systems or platforms that your healthcare partners are already using or familiar with, and it could be a solution to think through how to handle electronic or make things as electronic as possible so that there's some information continuity and standardization. But because they're already in existence and already addressing things like risk management and HIPAA compliance might be a solution that would be worthwhile to pursue. If you are operating without an electronic health record, consider working with the health information service provider to explore options for e-referrals. So health information service provider organizations that they manage security and transport for health information exchange among healthcare entities. Using specific standards for communication. So we talked a little bit about one of the methods that we used in this project was direct messaging, and health information service providers can handle direct messaging. They can support direct messaging for communications. In terms of project planning and scope, Susie mentioned this, and you guys and all of you on the call who have been working in this space probably also know this, that each of your healthcare partners or different healthcare entities that you might be working with, they're unique, and they might all require different approaches. So even if you are able to develop an approach for how we will receive referrals and how we will share feedback with our healthcare partners, it might not apply from one partner to the next. So being nimble, being flexible, and being prepared to potentially, if you are working with multiple partners at once, to adjust how your bidirectional communication pathways might look. Just something to keep in mind, because again, they not only might they be on different systems, but they might have different needs, or as Susie mentioned, they might have different requirements for what type of information to include in the feedback or the progress updates that you're ideally providing on their patients. We want to work collaboratively to ensure mutual understanding on timeline, communication channels, staff roles, and plans for ongoing evaluation. Again, just kind of echoing some of what we talked about from a relationship building and management perspective. As you think through workflow development, again, we recommend where you can to build off existing workflows, just ideally to help make sure that the process for identifying workflow maybe isn't too lengthy, but also if there are existing workflows that have been shown to be successful for your healthcare partner, are there ways that you can just leverage that and just will be less taxing both for the clinical staff as well as your staff if that's possible. But thinking through as you develop these workflows, what are going to be your processes for how referrals will be handled once received? We found that those healthcare partners do want to have a sense of what happens when you get this referral. What can our patients expect, and what can we expect? Being clear about what information you need as part of the referral, identifying, working with your healthcare partner from the beginning to determine what information is needed as part of the feedback loop. And again, being really clear about that up front so that we can make sure we're not only that we're not providing information that isn't necessarily useful to our healthcare partners, but that we're also not promising to provide information that is very difficult for us to pull together, or maybe that we don't even have the ability to capture. So thinking through that piece, just so that we're not over-promising and we're making sure that this referral relationship and communication relationship meets everyone's needs. How and when data can be shared, and as Susie mentioned, how successfully will be measured. In some cases, we found that as these partnerships solidify and as you work to identify what your goals are and what your scope is and what your benchmarks are, that there might be some benefit to developing formal agreements with your healthcare partners, whether it's a memorandum of understanding or just a contractual relationship, just thinking through how that might help with increased and shared accountability. And then if you have to prepare anything related to HIPAA compliance, making sure that you're being thoughtful about that up front, because we want to make sure that we're protecting participant privacy and that we're making sure the information that we capture and transmit is kept secure even when it's outside of the electronic health record. Some overall high-level suggestions or recommendations around implementation and evaluation. So what we've seen is that it's helpful to really hit the ground running as much as possible to try to begin implementation. And when I say implementation, I mean actually starting the process of receiving referrals or testing those processes as soon as possible, so that you and your partners can focus on joint and immediate problem solving. Found that there has been some benefit to that as opposed to a very lengthy planning process that, lengthy planning process before implementation starts, because then you run the risk of, unintended delays if there is staff turnover, or because there are competing priorities often both for you and your healthcare partner, that could inadvertently push things back. So it's also helpful, at least again from the experience that we've seen with local YMCAs specifically, that this idea around joint problem solving does also help to increase shared accountability and that sort of similar investment for both partners. So kind of hit the ground running and think about how you can iterate and assess as you go. We found has been helpful for getting this work off the ground or getting this work off the ground successfully. You might want to consider starting initially with paper-based referrals if you aren't already doing this work. There may be some value in refining just some of the communication pieces, like how can I make sure that I'm acting on this referral, and how do I make sure that I'm communicating back with my healthcare partner on referral status in the way that meets their needs and in a way that I can feasibly capture. Thinking through whether it makes sense to start there and then work on moving that to an electronic process. It might be worth trying that. In some cases that you might find that paper-based communication, that meets your needs, and that's where you want to stay, and that's fine. It goes back to your assessment and the time you spend identifying where you want to go with this work. So as Randall shared, when we were talking about the project itself, our original goal was let's come up with, or let's learn and then share what is the process for making a bidirectional electronic referral or communication pathway, putting that into place for lifestyle change programs. And as we learned very quickly, it wasn't going to get to that point. It's more about how do we help other organizations think through how they might approach this work. And it could be that the way to be successful in your community is to focus on paper. So we just offer that as a suggestion to consider if that's a place that you want to start, and maybe that's a place that you want to spend most of your time. Susie mentioned this already, but being prepared to test different approaches over time, iterating as you go, working through problem solving as you go, using the goals that you set for assessment and evaluation to determine where you might make adjustments That's going to be helpful. You might end up in different places with each of your healthcare partners. Things are going to go at different paces depending on the staffing involved, depending on the needs of each community or each partner. But just being prepared to modify your approach over time, because you may not be able to start out the gate with something that is going to end up being the most successful approach. And then communicating regularly to share feedback. There might not be, if we take a program like the National DPP as an example, depending on how many programs or how many people you are serving on an annual basis, or depending on the time points when you might be providing feedback to your healthcare partner, there might not be super frequent points of contact with your healthcare partner. So being really thoughtful about how you build in communication over time and throughout the course of your implementation so that you can continue to address issues. Susie talked about an example where referrals were coming in, and then after 6 months they sort of dried up. If you have those regular communication channels, you might be able to anticipate that a little bit better to be able to be proactive in how to address those. And as much as you can, use data when possible to assess your work so that you can make informed decisions around how you might recalibrate. Okay. So in summary, just a quick summary slide, and then I'm going to we'll answer some questions that have come in the chat box. But remember, this is a marathon, not a sprint. We know that this work is can be very cumbersome in some places and time-consuming, and it can take time. I mean, we've seen in the community, where local-wise specifically have started to build relationships with healthcare partners that have been 1, 2, 3 years in the making before it got to a place where it could be really more intentional around this type of referral and feedback loop. And again, that's where that internal assessment and ongoing assessment probably is going to be really helpful to be prepared for that. That's not to say it's always going to take a long time, but that it can. We might not be getting the referrals or the volume of referrals that we would ideally like very quickly. It's not always a single or straight path. You want to stay the course. We talked a little bit about embracing trial and error. There may be roadblocks and they can feel challenging, but the results can be well worth the effort. And to be prepared, going in with eyes open and expecting that you might hit some challenges and working collaboratively with your healthcare partners on how you address those will be helpful. And remember that you're not alone. So there is a lot of work in this field, a lot of energy that's being focused on this area. So, CDC, as I mentioned before, NACDD is doing a lot of work around this, AMA, and so a lot of energy trying to figure out what are ways to support the growth of bidirectional communication, whether it's electronic or not. So reaching out to others in your network can be helpful to know that there might be existing processes or existing learnings that you can leverage, so it doesn't feel like we are all independently starting from scratch, that we're working together to develop more solutions. So I'm going to pause now, and I know we've gotten some questions that have come in the chat. So we have about 15 minutes, so we'll take the questions that we can. So first question that has come in, let me expand this. So we've met with our local providers a number of times, and I'm assuming this means healthcare providers. So we've met with our local healthcare providers a number of times, and they seem interested in referring, but then we never get anything from them. What would you recommend?
So yeah, this is Susie. I can take that one. I mean, you're definitely not alone. We've definitely heard examples of this, and we know this can be frustrating, especially as we've been talking about, a lot of kind of investment of time goes into meeting with providers, and there's a lot of excitement, I think, at that initial meeting or even subsequent meetings when talking about all the opportunities that could come of this. But I would say, I mean, I don't think there's a silver bullet for this, but I do do think it's important to kind of revisit some of what we were covering in the driver's section. So, you know, for example, we were talking about the competing priorities that healthcare providers and systems face. So, you know, it could be that whoever you met with absolutely wants to make those referrals, but it's just fallen off of their radar, or something else has kind of been given a priority, and it wasn't necessarily up to that individual or group of individuals to make that other thing a priority. So important to, I would say, you know, be persistent, be consistent, go back to those individuals that you met with, go back to that organization. You know, think about, if you didn't already, is there a single champion or a couple of champions we can identify? That way you have a person or a number of people that you can hold accountable for whatever you discuss when you do meet, in terms of how you want to operationalize referrals. We talked about the importance of coming up with shared goals and commitments. So if that wasn't something you did initially, that would be something to consider. And if you can document it, even better. You know, thinking about evaluation and thinking about, you know, as we've been talking, just continuously assessing what's working and maybe what's not, and then kind of focusing on those things that aren't working. You know, let's try something different. You know, maybe it worked with a different partner, but it's not working with this new partner, so let's revisit. So definitely understand this is a challenge. It doesn't mean that you failed. We would just, I would say, recommend kind of going back and looking at what you have done, what maybe you could still try, and not losing faith, just, you know, being persistent and keep trying.
Cool. Thank you, Susie.
Yeah.
Okay, here's another question. In terms of the feedback loop, what information do healthcare providers typically want to receive, and how frequently?
This is Randolyn. Yeah, I can take this. So, you know, as Susie mentioned in part of the driver section, it's definitely provider specific, and it's important that you have that conversation with the provider. What are they looking for around the detail of that feedback and the timeliness of that feedback? We also mentioned that you know, closing that feedback loop is very important for the providers with that value-based care, and so, you know, you want to definitely make sure that you're following up with them around whether or not the people that they referred did in fact enroll. And then if they did enroll, you know, maybe it's sharing information about their attendance, their % weight loss in the program, and any other pertinent information that that maybe the provider wants to see specifically around those referred patients.
Cool. Thank you, Randolyn. Let's see. So a few questions about, again, about the slides and the links, the community assessment links. We'll make sure we can paste those links into the question box for those who asked for them, but we'll also make sure that those links get highlighted as the slides get shared and the recording gets shared as well. And just FYI, those links for the organizational assessment, those are just some examples there, and there's tons of them out there. I mean, you could really just do a Google search, you know, assessing organizational capacity. You'll probably find a host of them. So we're not saying that those are the only ones you should use, or even that those are the best ones you should use. We just wanted to make sure we offered some examples if it's maybe something that that type of work is new to you. So so we'll just make sure that those are made available to others, to folks on the webinar. I just wanted to thank everybody for attending today, and I know Randolyn also said this, but thank you to the local YMCAs and their healthcare partners who participated in this project over the last couple of years. We just learned tremendously from that experience, so I wanted to give another shout out to all of their hard work, and I know some of them are on the call today, so thanks for that.
Thank you. Thank you so much to the YUSA team, those who put together this webinar, but also those of you who have participated in this project over the last 2 years. It has been a great learning experience, and we really think it's going to help move things forward with regards to improving enrollment and referrals into the National Diabetes Prevention Program. Just want to remind people that if you're interested in learning about the bidirectional referral program from the perspective of the American Medical Association, we will have a third webinar. This webinar will take place on September 24th from 1:30 to 3 p.m. It should be included in the same invite that you received for this webinar. AMA will summarize key learnings on how to implement a bidirectional referral process in a healthcare system. They have interviewed healthcare providers and healthcare systems as part of our broader project, so they'll be talking about that. If you have additional questions or you want to pull in some of your healthcare provider, healthcare system partners to attend that webinar, I think that would be really helpful. So that's it. Thank you all for your time. We really appreciate you attending, and again, thank you to the Y for putting together the slides and participating in this project, and thank you to Deloitte for helping host this webinar.